All right, it's just about 9 o'clock, so we're going to get started. My name is Noah Canvasser. I'm endourology faculty at UC Davis. I'm going to talk today about surgical management of stone disease. I do want to thank, obviously, the organizers. It's unfortunate that we have to put this together given this time, but I do appreciate the organizers, Dr. Hampson, and everyone for allowing us to give this talk. And I do wish everybody a safe and healthy next few months, or however long it takes till this all goes away. So I am a consultant for Boston Scientific. I'm going to try to refrain from really recommending any product today. I think that it's certainly a preference, and there's lots of different devices that can be used. The objectives today, we're going to review case selection criteria for stone surgery, some landmark stone surgery papers. We're going to review the 3 contemporary stone surgical procedures: ureteroscopy, PCNL, and shockwave, in that order. I'm not going to talk about laparoscopic, robotic, or open approaches to treat stone disease. And specifically looking at equipment, techniques, outcomes, and complications of these techniques. But I do want you to remember that regardless of what I tell you today, your attending is always right. Again, there's a lot of preferences and opinions related to some of this stuff. Obviously, there's good literature supporting the things I'm going to talk about. But if you are in a case and you say, but Noah said something, just remember your attending is going to be right every time. So let's talk about case selection. When we're thinking about lower pole stones less than 10 millimeters, you really can choose either ureteroscopy or shockwave lithotripsy. This is based on a very prominent study, lower pole 2. This was Dr. Pearl and the lower pole study group. It was an RCT comparing shockwave and ureteroscopy for stones less than 10 millimeters in size. You can see that the 3-month stone-free rate was lower, actually, for shockwave lithotripsy, and second intervention rates were higher for shockwave lithotripsy, although these were not significant. But 90% of patients who underwent shockwave lithotripsy would choose that procedure again, compared to about 60% of those with ureteroscopy, which speaks to the less morbid option. So given this, we consider both reasonable options. And of course, you could argue that maybe this study had lower enrollment, and so possibly underpowered to show any significance in the stone-free rates. For larger stones, the guidelines are going to say that PCNL is recommended. That's why I underlined it here. But obviously, for the mid-size lower pole stones, ureteroscopies could certainly be considered on a per-case basis. We'll talk a little bit about single-use scopes later, but that might be kind of the stronger indication to use a single-use scope given potential for scope damage. But the indication to do PCNL for lower pole stones is based on another landmark paper, lower pole 1. This is again an RCT comparing shockwave and PCNL for stones less than 30 millimeters in size. Mean stone size was about 14 millimeters, but you can see a fairly significant difference in 3-month stone-free rates between PCNL and shockwave, along with a higher second intervention rate for the shockwave group. And there was really no main difference in the quality of life outcomes that they looked at. For non-lower pole stones, less stringent on the guidelines, certainly less than 10 millimeters, shockwave lithotripsy and ureteroscopy are both reasonable options. Greater than 20 millimeters, certainly you're going to start thinking about a PCNL. However, in kids, you could certainly consider shockwave lithotripsy, but the guidelines are clear that if you're going to go for a large stone, you should incorporate some form of drainage, either a stent or a nephrostomy tube. For those mid-sized stones, again, the guidelines are going to probably lean more towards shockwave and ureteroscopy, although I do think the PCNL, especially when we're talking about, say, mini PCNL, could be a strong consideration for some of those mid-sized stones. What about ureteral stones? So proximal ureter, typically we're thinking about shockwave lithotripsy or ureteroscopy. Although I think larger proximal ureteral stones, getting up to that 2 millimeters or 2 centimeter size, could certainly consider PCNL as a reasonable option. And for mid and distal ureter stones, it's pretty clear that ureteroscopy is going to have a higher stone-free rate, but also more morbidity compared to shockwave lithotripsy. But although this focuses on surgery, I think it's also important to note that observation is very reasonable for any asymptomatic calyceal stone. For most patients that I see who are not having any symptoms, I typically tell them they've got somewhere between a 15 and 30% chance of having a symptomatic event over the next 3 to 4 years. Obviously, that's a broad range, but really the emphasis is that greater than 70% of patients are not going to have an issue in the near future. So that not everybody actually needs a surgical intervention. Certainly, there is a higher risk of progression of these stones, of growth of these stones, and that's why we focus on medical management. But there are some considerations for patients who do have asymptomatic stones. Certainly, if you're working with a pilot or a military personnel, you might want to consider treating those asymptomatic stones. A young female who has planned pregnancy in the near future, that might be a strong consideration to treat an asymptomatic stone. Or somebody who's going to be traveling or maybe have poor access to medical care in the near future, that might be another scenario. We use Murphy's Law kind of predominates whatever could happen. So let's get into techniques. So ureteroscopy. So the rates of ureteroscopy are climbing. Over the last 20 years, we can see that ureteroscopy as a percent of total treatments has been rising worldwide. US falls in this sort of brown line here that you can see obviously climbing along with all the other countries reported in the study. Concurrently, we see a decline in shockwave lithotripsy. So it's essentially that the ureteroscopy cases are taking over some of these shockwave cases. You do see a little jump in shockwave here, but for the most part, shockwave rates have been decreasing. I think some reasons for the trend are one, residency training. Residents are getting exposed to a lot of ureteroscopy, but two, the technology of ureteroscopy is improving. So the first ureteroscope was really reported on in the early 70s. It was a small contemporary sized scope, 7.5 French, but it only had 30 degrees of passive deflection, which really isn't enough to treat any significant stones. The initial large series on flexible ureteroscopy by Dr. Fuchs in 1990 had a larger scope, 10.4 French, but this obviously had a functional working channel, similar to what we deal with today. But deflection was still a bit limited, 160 degrees in one direction, 70 in the other. Contemporary scopes typically are about 7.5 French for the fiber optic, a little bit larger for the digital. They most all have a 3.6 French working channel and now can deflect 270 degrees in both directions. There are concerns, though, about reusable scope durability. Most scopes don't last forever, obviously, and there have been a number of studies looking at how long they do last. This study published about 27 cases per scope, and then once they actually get repaired, the repaired scope lasts tend to be shorter than the original scope. Most of the time, this damage tends to be at the distal shaft from forcing or torquing that scope into a difficult area. Single-use scopes have really gained a lot of steam over the past 5 or so years. Most of these are a little bit larger than their digital counterparts, but they all work quite well and are functional for the needs. They are a bit expensive. There have been some studies that show that single-use scopes actually could have similar per case costs to a reusable scope. Obviously, that's on a per institution basis. Obviously, the environmental impact is also concerning, although there's a study that shows that the lack of cleaning scopes and the waste from reprocessing scopes might be equivalent to the waste from production of these single-use scopes. I think that most people agree that a selective use of single-use scopes is prudent. Certainly a large lower pole stone where you're going to be torquing a bit for a long time, or in a patient who's got tortuous anatomy, are both reasonable indications to use single-use scopes. So let's talk about flexible ureteroscope manipulation. This might seem a bit elementary, but I think it's kind of a good review. So there's 3 ways you can move a scope. You can go in and out. You can deflect up and down. Obviously, that depends on if you, or the thumb action depends on if you have a standard or reverse deflection scope. But it's really the rotation where I find that most trainees struggle. Sometimes you have to take a step back and think about the movement that you're using. So if you are deflected up, the rotation of your scope is the same. And if you rotate to the left, your scope looks to the left. If you're deflected down, your rotation is opposite. And I made a little video to kind of highlight this. But here's an example showing downward deflection. I rotate to the right and the scope looks to the left. Downward deflection, I rotate to the left and the scope looks to the right. And then with upward deflection, again, it's the same. Rotate left, rotate right, look right. And so if you're ever in a case and trying to figure out how to get into that last little calyx, just stop for a second and think to yourself, are you rotated down or are you rotated up? We're going to talk about my preference in a second, but if you think from that aspect, oftentimes you can stop guessing and actually get it right on the first try. So when we think about flexible nephroscopy, it's important to remember the axis of the kidney. So the way the kidneys lie on the body, the calyces are actually posterior to the UPJ, to the entrance of where your flexible ureteroscope enters the kidney. Therefore, you have two ways to get to the calyces. You can rotate up and rotate toward, deflect up and rotate towards the calyces, but that puts you in an upside down position. So the better option is to flex down and rotate away. So we always talk about as we enter the kidney, we rotate away from the side that we're on. So this is just a brief demonstration of flexible nephroscopy at the end of a case. So this is actually the upper pole here, so it's medial to our UPJ location. So we do rotate. There's a left kidney, so I'm rotating to the right there. But all the other calyces, as we go through them, again, this is a left kidney. My rotation is going to be to the left. So again, we rotate left to look right. And as we rotate through the kidney, the goal is to try to keep the calyx in view as you're backing out so that you don't fall upon that infundibulum and your angle. And as we go down to the lower pole, all we're doing is rotating more and deflecting more. And I think this is really helpful to think about this in this way, because sometimes you have a case that's a little bloodier, you can't see as well, and you have to kind of drive by feel. So I paused the video right here where you can see the angle of the kidney. Just that slight rotation to the left, again, to look right, puts the calyces in line. Moving on to semi-rigid ureteroscopes. So Hugh Hampton Young actually gets credit for the first semi-rigid ureteroscope ever performed. He drove a rigid cystoscope into a megaureter. I believe it was an accident. But it wasn't until about 80 years later that we first started to see semi-rigid ureteroscopy take hold. This was a 7.2 French dual channel semi-rigid scope. Contemporary scopes all are around this size now, 6 to 8.5 French. They pretty much all have dual channels. These are independent, so you can irrigate through one and work through the other. And this is great for doing ureteroscopy in the distal and the mid-ureter. In women, sometimes you can obviously get into the proximal ureter as well. A nice technique when doing semi-rigid ureteroscopy, I don't do a lot of balloon dilation of the ureter. So if I can't get in just on the first try, then we tend to do what's called tram tracking. So it's where you feed a second wire. In this case, we see a Benson wire going in to the ureter as well. And the goal is to split the difference between the two wires. Obviously, you want to hit right in the middle. In this case, you'll see that I slipped around that second wire. And I always say, if you're not in a good position with semi-rigid ureteroscopy, back that scope up. So we flipped. So we back that scope up. And realign, and again, split that difference between those two wires, maybe a little twisting action with the scope, and you'll get in. And using this technique, obviously a lot of people use this technique, really helps to prevent or the need for balloon dilation of that intramural ureter. Let's move on to lasers. Initial lasers, these were pulse dye lasers, Coumarin dye lasers. They were fairly ineffective for treating hard stones. And in addition, they required replacement of the Coumarin dye, which is toxic and I believe a bit messy. Obviously, holmium YAG lasers really revolutionized kidney stone treatment. HOYAG lasers have a wavelength of 2140 nanometers, which is similar to the spectral absorption of water. And what this means is that essentially the depth of penetration of your energy is low. So the risk of injuring nearby structures is quite low. But these lasers are strong and powerful, and so they really can break up pretty much any stone. More recently, we see the kind of reemergence of thulium laser, thulium fiber, which also has a wavelength that's similar to the spectral absorption of water. In addition, the damage zone of, or because of this, the damage zone or the depth of penetration of thulium is even less than holmium. The real benefit of thulium compared to holmium is that thulium are a very high efficient laser. They only require 110 volt, so you get a lot higher potential frequency, which might help for, say, dusting treatments. Let's talk briefly about laser settings. So when we think about power, this kind of gets back to physics. So power is equal to energy per unit time. But in terms of our laser, we think about the wattage in terms of pulse energy times the rate or the hertz. So pulse energy. So a higher pulse energy, a higher joules, controls pulse energy controls fragmentation efficiency. So a higher pulse energy means you're going to fragment that stone more efficiently, faster. The downside, though, is you're going to have larger fragments. You're also getting more retropulsion of the stones. When you have a lower pulse energy, a lower joules, you tend to have slower fragmentation. You'll have smaller stone size, but you will have less retropulsion. So it's a balance, obviously, when we're treating this. We decide the pulse energy really based on the stone location. Is the stone, say, in the ureter without a backstop, where if you hit the stone with a lot of energy, it's just going to retropulse higher up the ureter, which is an ideal? Is the stone in the renal pelvis, where it's going to move around a lot? You hit it, or is it in a calyx that has a nice backstop behind it, where you can hit it with a lot of energy and it's not going to move around a lot? Also, the density of the stone. Certainly, a more dense stone is going to need a higher pulse energy in order to fragment. Typical range for most machines, most lasers, is 0.2 to 2 joules. As far as choosing the rate or the hertz, this controls the fragmentation speed. So the higher the rate, the more the fragmentation, but also the more the retropulsion. The lower the rate, less fragmentation and less retropulsion. Again, we choose this based on really the stone location. Again, a free-floating stone in the ureter of the pelvis is probably going to move around a lot more than a calyceal stone with a higher rate. In addition to stone size, a smaller stone is going to move around a lot less. I'm sorry, a lot more than a larger stone. So a larger stone can probably tolerate a faster rate. And this is really where we see the difference in contemporary lasers. A typical range for a laser is 60 to 80 hertz. Obviously, the higher wattage lasers are really what's going to give us that 80 hertz or even up to 100 hertz option. A lot of contemporary lasers allow you to control the pulse width. Think of this as like the energy density. So for each pulse, that pulse can be, or that watt can be given over a short period of time, or can be given over a longer period of time. So short pulse width is better for fragmentation because that energy is applied quicker, so it's a bit stronger. You do get more retropulsion though, and there's potential for more fiber burn back. With a longer pulse, you'll get more of a dusting effect, tend to be less retropulsion and less fiber burn back. So putting this into practice, turn my sound down. So standard fragmentation technique, so 0.8 joules, 8 hertz, typically a short pulse mode if you have that option on your laser. We tend to even use what's called, I use it called a single shot technique, where we're actually individual taps on the pedal to hit the laser. And you see that the stone stays in fairly good control in order to fragment it into small pieces. So we chose a moderate pulse energy, a low rate. It's fairly well controlled, but we do get large fragments with this. Obviously, this is for somebody who's, say, going to be extracting a lot of these stones, like myself. Conversely, dusting is a technique where we tend to use a lower pulse energy and a higher rate. So the inefficiency in breaking up a stone with a low pulse energy, make a lot of small stones, is overcome by the high rate, so that you can actually make a lot of stones, or a lot of small stones, quickly. And if you have the option to use a long pulse mode, that is certainly advantageous. The popcorn effect. So this is somewhat of a middle of the road technique. So we tend to use a more of a moderate pulse energy and a moderate rate in order to fragment a lot of stones into smaller pieces. It's not going to be as small as, say, dust, but it can be relatively efficient. The downside is you tend to have a big pile when you're done, and it's hard to tell what's large and what's not large, but it can be used in certain scenarios. Let's talk about ureteral access sheaths. So the goal or the benefit of a ureteral access sheath is that it reduces renal pelvic pressures, which leads to lower infection rate. This was the Traxer study that showed that stone-free rates were really not different between ureteral access sheath use and without a ureteral access sheath, but infection rates were lower. So rates of fever were lower and significant rates of sepsis were lower. So that's really where the benefit is. It does allow multiple passes, but again, does not seem to improve stone-free rates. I think that is on a provider basis. The downside of ureteral access sheaths obviously are the concern for wall injuries. This photo has been shared numerous times and presented numerous times, obviously also from one of the Traxer papers. And yes, these can be quite concerning. Rates of the severe grade 2 and 3 injuries that you see on the right were about 13%. There has been a prospective study looking at rates of stricture after severe injury, and they appear to be quite rare. I think that most of the time we see ureteral strictures after more of the severely impacted stones as opposed to these injuries from an access sheath. Stents. Most people, or a lot of people, put stents in after ureteroscopy. However, there's been shown no difference in UTI, strictures, unplanned ER visits, or stone-free rates for whether or not you use a stent. I don't think stents are required. I think it obviously is a preference of the provider. And the guidelines pretty much state that if there's no evidence of ureteral injury, no evidence of ureteral stricture, you have a normal contralateral kidney, no chronic kidney disease, and you're not planning to come take a look again, you do not have to leave a stent. Yeah, we'll leave it at that. And then briefly looking at outcomes. So you'll see a lot of different published reports of stone-free rates after ureteroscopy. This is the work that we had done at Southwestern when I was a fellow with Dr. Pearl. It is not yet published, although we hope to publish it soon. This is true stone-free rates for all comers. And you can see that a 55% is a lot less than what you might expect to see in the literature. And it just means that we're not as good as we think we are. And this, by the way, I'll mention is a very aggressive ureteroscopy approach where we're trying to truly extract every stone fragment in the kidney. Now, there are some scenarios where I think we do a pretty darn good job. So any ureteral stone, we have a pretty good clearance rate. As well as any solitary kidney stone less than 10 millimeters, we do a pretty good job. But if you're starting to talk about larger stones, multiple stones, we're really starting to get to poor clearance rates. And again, I can't emphasize enough how much time and effort we spent trying to clear every single stone fragment. We just aren't as good as we think. Complications of ureteroscopy. So the things that I certainly tell my patients, so failed ureteral access. So I'd say it's about 1 in 30. Obviously, this is a wide range here from this meta-analysis, but I typically say it's about 1 in 30 that I'm unable to get a scope into the ureter. Certainly rates of fevers and UTIs post-procedure up to 15%, but sepsis rate typically less than 4%. Obviously lower if you're going to consider using a sheath. And then strictures tend to be rare, but that's why you should be screening for patients who are at risk. The more rare risks of urinoma, perirenal abscess, ureteral avulsion, or obviously mortality are really quite rare. So let's talk about percutaneous nephrolithotomy. So Fernstrom and Johansson were really given credit for the first PCNL. They removed small stones via mature nephrostomy tract in the 70s, but 5 years later was when we really start to think about what we consider contemporary PCNL. So Dr. Alkin would dilate, and his group would dilate a mature nephrostomy tract to 26 French, leave it for 5 to 6 days prior to the procedure, and then actually go in with a scope, fragment stones, and remove. Regarding access, there often is debated urologist versus radiologist access. Published reports have said that radiologist access is often not effective, and I don't think that's really a fair criticism of radiologists, because they're not the ones doing the stone surgery. I think that if you're going to have your radiologist get access for you, you should probably be in the room and help guide them to where you want it. And we're going to obviously talk about access in a few minutes. But oftentimes radiologists are not thinking about treating the stone. They're often just thinking about getting the tube in. This study did show that access-related complications were higher in a radiology group compared to a urology group. Again, I think it depends on how much role you played in that where that tube was placed. I will say, though, that if a nephrostomy tube was ever placed for an emergent scenario, it is rarely effective. This was a nice study by Dr. Cobb showing that only about 1 in 5 tubes placed emergently were actually suitable to complete a PCNL. So if your tube was placed for urosepsis or AKI, yeah, you probably need to pick a different spot. So let's talk about access. There's so many different ways to get access into the kidney. So you can use a triangulation method, a bullseye method, endoscopic, ultrasound. You can have IR do it, obviously. You can do it in the supine position, in the prone position. You can do it left-handed. You can do it right-handed. It really doesn't matter. Whatever technique you can use to get the needle in the right spot is going to be the best for you. There are some general principles, though, of good access. So one, you want to hit a posterior calyx. Certainly, a lateral calyx, if there isn't anything lateral to the kidney, could be considered, but a posterior calyx is going to be typically ideal. You want your needle parallel with the infundibulum, with the goal to access on the papilla. Going right through the papilla or the fornix are both reasonable options. And the needle angle, and I'll show this with some diagrams in a second. So the needle angle should be pointed towards the ureteropelvic junction. In general, at the lower pole, the needle angle is going to be steeper. At the upper pole, shallower. At the upper pole, the needle angle is going to be steeper. And I say here, do not fear the second choice. So if you can't get the access that you want, due to angle, due to rib, due to nearby organ, pick a different spot. As long as the second spot is still a good, follows these principles, you can always use a flexible scope. You can always use a laser, fragment stones into big pieces, and then suck them out of the renal pelvis. But never hesitate to use the second choice access point. So let's talk briefly about needle alignment. So if you're going to go for the upper pole here, hitting the calyx like this is probably not going to be ideal. You want to obviously be in line with the infundibulum, again, that principle I just told you. So again, mid-pole access, you need to be in line with the infundibulum. Same thing with the lower pole. The goal is to line your needle up with the infundibulum. That way you're going to cause less torquing on the calyx, on the cortex of the kidney, typically less bleeding as a result. Regarding the needle angle, again, the needle should be pointed towards the ureteropelvic junction. So if you're going towards an upper pole axis, having a needle that's going up as well is probably not going to be ideal. In addition, think about the sagittal plane of the kidney. The upper pole tends to be in a more posterior location. So that would be a reasonable access point, or maybe that would be a reasonable access point. A little bit towards the UPJ is more ideal. Mid pole is very similar to the upper pole. I think the issue comes with a lower pole access point, where a straight-on needle puncture is probably not going to work because the UPJ is obviously going to be up here, right? So you need to slope up, have a shallower angle in order to get into that lower pole. However, too shallow of an angle, which we sometimes see with nephrostomy tubes, again, it's going to put you a little bit too far away, and your sheath's probably not going to be long enough. And typically with obese patients, you need to exaggerate these angles a bit more just because the kidney is deeper. So again, upper pole access, typically straight on or a slight angle towards the UPJ, but with a lower pole access, you need to have a steeper angle in order to get in. Briefly, calyceal anatomy. So at the lower pole, typically there are 3 calyces. Okay, you have the inferior calyx, the posterior calyx, and then an anterior or lateral calyx. And we often say that the posterior calyx is door number 2. It's the second calyx up from the bottom. And that tends to be your best posterior access point. For upper poles, again, because the upper pole of the kidney sits more posteriorly, typically both axes are reasonable. And oftentimes there's a medial and a lateral calyx, and both, again, would be reasonable choices. For a mid-pole calyx, I think it's a bit harder to see on fluoroscopy. I think it's an easier access on ultrasound in order to hit that calyx. Obviously, there's a lot of variation in calyceal anatomy. This is just some general guidelines. So here's just one example of access. This is done with fluoroscopy because I think it explains the point a little bit better. This is a large renal pelvic stone. You can see an occlusion balloon is here. So this was done with an air nephrogram. And you can get a sense for where might be a reasonable access. So that is probably the lateral upper pole calyx. That'd be a reasonable access point. You have a mid pole calyx here. That's a reasonable access point. And you can also see door number 2 right there, lower pole posterior calyx is a reasonable access point. We already did the triangulation here to figure out that this was in fact the posterior calyx, and you can see my hemostat there picking my entry point. So as we access this kidney, again, the goal is to keep that needle in line with that infundibulum. In the straight AP plane, we are advancing the needle until the tip is just at the calyx. And I chose this one because I think it's a really good example that we use oblique views to check the depth. So the C-arm goes oblique, takes a shot, you can see how far in that needle end is. So that needle is a bit too deep. So I take it out, I keep the same line, I'm just gonna be shallower, right? Lower pole, shallower angle. Again, hit the calyx, take an oblique shot. That's much better access. Obviously, it takes months and months to really get comfortable with access. The more you do it, and the more you see, obviously, the more comfortable you'll be. So I wanted to talk about flexible nephroscopy briefly. Flexible nephroscopy really should be a part of most standard PCNL cases. I say that this is where you earn your outcomes because all those little fragments that are floating around, this is where you're going to find them. And to keep orientation, I tend to teach our residents that they should deflect up and rotate towards the pole. Obviously, this is a bit different than when we do flexible ureteroscopy. This does put us in somewhat of an upside down position, but it helps us to keep orientation where the calyces are. Again, another brief video. So starting at the upper pole, this is the same case. So we're rotating up towards the upper pole, we're rotating up, rotating towards the mid pole. Typically we do a little bit of contrast in a spot fluoroscopy to confirm the calyx that we're in. Again, we're rotating up and towards the side that we're on, another spot with some contrast. And then finally for that lower pole, we're going to rotate our hand all the way around to keep that orientation. I find that going upside down or backwards is a bit tricky. So I tend to, again, deflect up. And the spot there shows us the lower pole. So if you look around, take a very detailed look, do it multiple times, you'll find all those little stone fragments that are floating around, get those out and improve your stone free rates. Briefly talking about sheath sizes. So a standard PCNL we typically think of as a 24 or 30 French sheath. I call it, this has functional suction. So you can really suck out all the clot that you invariably will see with most PCNLs, but also you can functionally suck out all the small stone fragments. With mini perc, typically ranging in size from 15 to 23 French. Most of these scopes are about 12 French with a 6 French working channel. A lot of people use laser for these. You can use a lithotrite. Most of those lithotrites are like 4 to 5 approximate French. So there's limited suction. So if it is a bloody case, if there's a lot of clot, you're going to have a little more difficulty with it. Now, smaller puncture, so hopefully less bleeding, but that can be a problem with bloody cases. Oftentimes this relies on the Venturi effect to remove stones, meaning you are creating a lower pressure system in the sheath due to irrigation, and the stones tend to fall into the sheath and out. I think my main concern with mini PCNL is the limited flexible nephroscopy, so you need to be really careful with case selection. If you're going to have a stone that's going to break apart into lots of pieces and float all over the kidney, you might not be able to go fetch those unless you do, say, ureteroscopy, flexible ureteroscopy at the same time. Ultra mini, even smaller, 11 or 13 French sheaths. These are even smaller scopes. Typically, you can only use a laser in these, and really, there's no great option for flexible nephroscopy. So you need to use a flexible ureteroscope to take a good look around the kidney at the end. Regarding drainage, nephrostomy tube is really the classic way that we drain patients post-PCNL. The benefit of a nephrostomy tube is typically it comes out before the patient goes home. So the idea is that the patient goes home without any stones and without any tubes. And we see that this is in fact improves patient quality of life. This was a nice study done by Dr. Zhao, showing that WisQual was improved at 7 to 10 days in patients who had a nephrostomy tube. However, I think we commonly see patients performed tubeless or with a ureteral stent placed. The benefit of the tubeless approach is, in my opinion, is that it almost guarantees that the patients go home on post-op day 1 unless they have some infectious complication or bleeding complication. In addition, those cases where we remove the nephrostomy tube and the patient has clot colic or colic post removal and they need to have a stent replaced, it essentially removes that potential as well. It also removes, in my opinion, the potential to form a uronoma and have that ileus that we sometimes see after nephrostomy tube removal. So, I do like to use a tubeless approach. Certainly, if I'm going to do a second procedure, a planned second look, I tend to leave a nephrostomy tube in place. Totally tubeless has been described for standard PCNL, although it is more common for the mini and the ultra mini cases. So outcomes of PCNL. So the CROWS study showed a 30-day stone-free rate of approximately 75%. This was a mix of various imaging modalities. I think that classically you'll see papers describe 90+% stone-free rates. I think that can often be debated. I actually really like this recent study. It's actually just in the literature now out of IU, showing true stone-free rates of around 57 to 65%. And I think this is what a lot of people see in practice. Again, this is looking at all fragments after PCNL. We aren't the 95+% success rate. I think we are more in that 60 to 70% range. But the number of times that we do a second look procedure is certainly less common. In the CROW study, it was about 15%. In the IU paper, I think 20 to 30% of patients. Obviously, some people are more aggressive with getting out every single stone, which I do agree with. But that is certainly a preference to try to retrieve every little fragment. Complications of PCNL, certainly the infectious complications tend to be most concerning, although rates of urosepsis are fairly low, less than 5%. Transfusion rates, although the range of this paper was up to 17.5%, I typically think it's in the 2 to 3% range. That's with kind of contemporary techniques. Uronoma, as I said, is fairly rare when we use a ureteral stent, but it is seen if you had say a pelvic perforation and you left a nephrostomy tube. The chance of a pleural injury and hydrothorax is also fairly rare, but increases with the supracostal access. This is a fluoro shot of somebody's chest after a supracostal access. You can see that dark line here signifying the hydrothorax that occurred. But the really severe complications, say mortality, pseudoaneurysms, and injuries to nearby organs are all quite rare. So last but not least, shockwave lithotripsy. So 1980, The Lancet, classic paper by Professor Chaucy, really revolutionized stone treatment, and I think had a lot of doubters when they said that they could use shockwaves to break up stones, but obviously they proved all of them wrong. We'll talk briefly about the mechanism of action. Obviously, you see a lot of this in the core curriculum. I just think it's important to note that stones break up due to multiple different forces. So you have shearing forces on the leading edge of the stone where the shock waves come in. You have spall fractures on the posterior edge where sound waves are essentially bouncing off the interface between the stone and the fluid around it, and then bouncing back towards the center. And because you've got waves coming from the front, waves coming from the back, you have super focusing of waves in the center of the stone to also break up stones. Because of the force of the shock wave, they create essentially a negative pressure behind them that creates cavitation bubbles. And as these bubbles fracture or as these bubbles collapse, that also creates a force that can help break up stones. So a lot of different forces at play to break up stones. There's 3 different types of lithotripters. We'll review them briefly. So EHL, electrohydraulic, these are the spark plug lithotripters. So you've got a spark plug that discharges in fluid that is then focused on this ellipsoid reflector onto the F2 focal point of the stone. These tend to be fairly strong lithotripters, but they can also be inconsistent with the strength of their shocks on a per shock basis. In addition, the lifespan of spark plugs is low, so they do often require more maintenance than some of the other machines. This was the classic Dornier HM3 lithotripter, was a spark or electrohydraulic lithotripter. Electromagnetic lithotripters. An electrical impulse is applied to these electromagnetic coils, which then move a membrane to create the shock pulse. It's then focused, obviously, down to the F2 point. These are more reproducible, consistent in their strength. These also tend to be a bit more durable than EHL lithotripters. But because of the small focal region of high energy that is created with this type of lithotripter, there is the potential for a high risk of hematoma. Lastly, the piezoelectric machine. So these have an array of ceramic elements that all are activated at the same time with an electric spark, the electrical impulse, and they then focus their energy on that F2 focal point. The benefit of the piezoelectric is because this is a large array, each individual shock from each element is quite low. So the full strength of the shock is delivered over a large surface area, so potentially there's less pain for patients, but also there's the potential to have a less efficacious treatment. So when we think about patient selection for shockwave lithotripsy, certainly the main criteria besides stone size that we talked about at the very beginning is going to be the stone density and the skin to stone distance. This was a nice study essentially comparing those two, and you can see that for patients with a softer stone, so less than 900 Hounsfield units, with a skin to stone distance less than 9 centimeters, has sort of the highest success rate. Conversely, a stone that has greater than 900 Hounsfield units and greater than 9 centimeters skin to stone certainly has a lower success rate. Other stone compositions, if you know the patient's history, certainly cystine stones are essentially resistant to shockwave lithotripsy. Brushhead stones are quite hard to break up with shockwaves, and calcium oxide monohydrate as well. But I would tell you that for something like a monohydrate or a brushhead stone, if you have somebody who's thin, it certainly could be considered, but just expect a lower success rate with those patients. So how to do shockwave lithotripsy? Again, I don't claim to have an extensive experience. I was in the resident groups that did, typically around 10 shockwaves throughout their training. But I do some now for patients that are appropriate candidates. I do get a KUB the day of surgery because you want to make sure that stone is radiopaque. Our machine is coupled to fluoroscopy, although there are machines that are coupled to ultrasound that you could avoid this if needed. I put the patient in a supine position if they're going to be renal stone, proximal, or distal ureter. I do a prone position for patients whose stones overlie the bony pelvis. I do general anesthetic. This obviously allows for better control of respiration. In addition, we use an EHL lithotripter, so it'd be a little more painful for a patient to be under local, but local sedation, totally reasonable for a piezoelectric machine. We typically start at a low energy and a low rate, 60 shocks a minute. After about 200 shocks, we do a pause. And the benefit of the pause is that there is compensatory vasoconstriction to potentially decrease the rate of hematoma. It only takes a couple minutes, and I think it's very reasonable and safe, and we can spare that time to decrease that risk. After the pause, we start to slowly increase the energy and increase the rate. There have been some nice studies looking at the effect of shockwave rate on success. In this study here, you can clearly see that when you get to 120 shocks a minute, your success goes down and your pain goes up. We tend to go maximum 90 shocks a minute. But for a stone that is, say, moving around a fair bit, I think 60 shocks a minute is very reasonable. It's really the same principle that you see with laser lithotripsy, where you have a lot of retropulsion with a higher frequency. The maximum number of shocks is really determined by the manufacturer of your lithotripter. Typically, you can put more shocks in the ureter than the kidney because there's less concern for parenchymal injury. Our machine, we can do 2,500 shocks in the kidney, 3,000 in the ureter. But you really should only use as much as you need. So if the stone appears to be breaking up nicely and you're done by, say, 1,500 shocks, then obviously stop. No need to put the kidney at risk by completing or by maxing out. Outcomes of shockwave lithotripsy, if you're looking at true stone-free rates, they're going to be on the lower side. So the lower pole studies showed, again, true stone-free rates of around 35%. You'll see some reports higher. Obviously, it just depends on how you define success. I tell patients that around 80% of the time, they're not going to have another procedure. So the rate of needing a second procedure is around 20%. So they might have some stones left in the kidney that fall into the lower pole that they don't pass. And, again, for most people, that's fine. They might pass them at some point down the road. You have to be cautious to make sure they're not growing bigger and focusing on prevention. But for the most part, 80% do not need a second procedure. Absolute contraindications, obviously, we review these often. So bleeding diathesis, so anybody who's on anticoagulation or has a known coagulopathy should not undergo shockwave lithotripsy. I do shockwave lithotripsy on a baby aspirin, and I haven't had any specific issues with it. And there's the literature to support that. Certainly pregnancy, you shouldn't do it. Active infection, you shouldn't do it. Or if you have a distal obstruction, you should not do shockwave lithotripsy. Complications of shockwave lithotripsy. So a clinically significant hematoma like that is fairly rare. If you scanned everybody after shockwave lithotripsy, you'd probably see some small hematomas, probably in that 15 to 20% range. Steinstrasse, or stone street in German, where they have a collection of stones in the ureter, happens around 5 to 20% of the time. Again, higher risk with larger stone burden. There have been reports on increased rates of hypertension and diabetes, although these have not been founded in subsequent issues. So I truthfully do not counsel patients on this. I typically talk about the rate of hematoma, the chance of a Steinstrasse, or just the chance that they have residual fragments altogether. So we're right at about 45 minutes. I'm going to stop there. And I didn't introduce Sun Nguyen at the beginning, but Sun Nguyen is one of our excellent residents here at UC Davis, and he was going to help coordinate the questions that were asked.
Yeah, I categorized the questions into 3 categories. The first is uteroscopy, so I'll start with that. There's a couple questions regarding that. In which cases would you consider placing a stent prior to the flexible uteroscopy, Dr. K. Ambassador? That's
a really good question. I know that some people certainly where you place stents. It is not part of my standard practice. I only put a stent in if I cannot get the ureteroscope up on itself. And obviously, we always talk about not forcing the scope. When I do ureteroscopy, after I get my first wire in, I use what's called an 810 dilator. So I put an 8 French catheter into the ureter, and then I put a 10 French right over that. Although it's listed as a dilator, it really is a calibrator. So it tells me how big that ureter is. And if the 10 French portion goes easily, then I tend to proceed to placing an access sheath. If the 10 French portion does not go easily, I typically do not attempt an access sheath, and then I'll try to put the scope in. But if the 8 French is really tight, then I'm certainly not going to be able to fit my 7.5 French scope in, and that's when I place a stent beforehand.
And to follow up with that, during intraop, we usually place a ureteral access sheath. And for that, do we typically place a stent, and for how long?
Afterwards?
Yeah.
Yeah. So I do place a lot of stents because I do use a lot of access sheaths. So I do think the ureter certainly gets a bit more irritated afterwards. Again, the Traxler paper shows that ureteral injury is grade 1 through 3 in 50% of cases, and I see that. But the vast majority of these are grade 1. But I would put a stent in for grade 1. So the only time I don't put a stent in after an access sheath is as you're doing a pull-out, if the ureter looks essentially pristine, if the ureter looks like it has no irritation, no injury, then I would consider doing stentless. Certainly they have to have a normal contralateral kidney in order to have that place. But in my experience, it's probably less than 10% that actually do stentless ureteroscopy.
And in your lecture, you mentioned that even with ureteral access sheath, the ureteral stricture rates aren't as high compared to impacted stones. So when you're treating an impacted stone surgically, how long do you typically leave the stents in for?
Good question. So And that was a prospective study by Karen Stern, Dr. Stern at Mayo, looking at rates of stricture after a ureteral access sheath injury. So if I have an impacted stone where the ureter looks really irritated, really inflamed, I tend to leave it in for 2 weeks. That tends to be the longest I will leave a stent in. Certainly a really severe injury, I mean, think something on the level of like an endoureterotomy type depth of injury, I'd probably do 4 weeks, but that's pretty rare. So I would say 2 weeks is at most for those really inflamed from impacted stones.
Got it. And in the community, some urologists tend to split up the ureteroscopy. They'll do one side and then come back to the other side later on. What's your opinion on doing both at once?
Yeah, I think a staged procedure is very reasonable. It depends on your equipment and timing, obviously, and access. I tend to struggle just getting people into the OR just based on how busy we are out here. So I figure if I'm in the OR and I've got them asleep, I'll go ahead and do both sides the vast majority of the time. So yeah, I don't hesitate doing a bilateral case. Certainly, if you're going to do a bilateral case, you have to leave a stent on one side. The second side, though, if the ureter looks good, it wouldn't be unreasonable to leave it without.
Got it. And then I'll move on to the S walls. You mentioned that stone size and then skin to density, or the density wise. What about, does a machine matter for that stone free rate?
Yeah, it's a good question. I think a lot of manufacturers will say that they can go to a greater depth. They can expand the indications, and I think that's just really on a per case basis. If I was a patient and I had to have stone surgery, I think shockwave lithotripsy is what I want. But again, you want to look at the stone parameters, the size of the stone, the depth of the stone, the density, and say, is it realistic that this is actually going to treat the stone successfully? And so I try to have that conversation. The lithotripsy that we use, it's a Storz F2. I think it even quotes up to 15 or 18 centimeters of depth. My personal experience, I haven't had that success at that point. So if you're talking about 15 centimeters skin to stone, I think there's going to just be a lower success rate. But that's, again, my personal experience with shockwave.
Just going back to the ureteroscopy really quick, if you notice extrav during the case, how long do you leave the stent in for?
Yeah, I mean, most of the time, if you had a forniceal rupture, will heal actually within about 48 to 72 hours. I mean, the same principle applies when we're doing, say, PCNLs. So I wouldn't leave the stent for any longer. Really, the length of time that I leave a stent in is really dependent on what the ureter looks like. However, if I did notice a perforation and extravasation, I might consider leaving a Foley catheter to help decompress if there was, say, concern for infection especially. But the length of time that I leave the stent in is really independent of a perforation.
And then one last question. In terms of patients who had a stone previously, came in with pain, however, became asymptomatic during medical expulsion therapy within 6 weeks, but they still have intermittent pain, do you re-image or proceed with OR, or what?
Yeah, that's a great question. Actually, Brian Eisner at the MGH recently had a paper, I think within the last couple of years, showing that about 25 to 30% of patients with asymptomatic stones attempted passage actually retain their stones. So I do a lot of re-imaging for patients who fall into that category. I tend to really push patients to strain their urine and be cognizant of if they pass the stone, because that would avoid that necessary step. I also don't like to, nobody likes to go to the operating room and find no stone there. So I personally would rather have a repeat imaging procedure before I have a necessary surgery. But if it's a distal stone that you're looking at passing, I think that you can do a limited CT protocol, the pelvis only, less radiation. Certainly there's a cost there, but less radiation, and know for certain. If the stones are radio opaque, if there is evidence of the stone on, say, the scout film from a CT scan, I think you can use KUB to follow. But a KUB that doesn't show the stone and the patient didn't see the stone, I think you have to really take that on a per case basis, because the worst thing we could do is leave a stone that is unknown. And actually, we do see that happen from time to time. So.
And I think that is it.
Great. Well, I did leave my email address at the beginning of the talk. Obviously, this is going to be recorded and posted somewhere, but feel free to email me with any questions. And again, please, everybody stay safe, and I wish you all well.